Yeah.
So Dr. Michael said, I'm the radio play-by-play guy for a local high school football team. I love this is amazing. I'm loving this.
That's cool.
This thing's firing up. That's awesome. Play
It's
by play
awesome.
high
That's
school
very cool.
football. Yeah, that's a great thing. That's a great thing. High school football, nothing like it. All right, so we're gonna get
Yeah.
started, everybody. I know we have a few more people trickling in, but I'm super excited to be here tonight and presenting. And a good friend of mine, somebody that I consider a good friend. Welcome to tonight's CE webinar, Beyond the Pros Concept: Achieving Optimal Tissue Stability with Socket Shielding and Surgical Guides. My name is Greg Essenmacher, and I'm the Vice President of Business Development here at 3D Diagnostics. Tonight's presenter is Dr. Jonathan Mish. He's a periodontist practicing at Pinckney Implants and Periodontics in Michigan and CEO of the renowned Mish Implant Institute, which I'm sure most of you have heard of for sure. He received his DDS and MS in periodontics from the University of Michigan, go blue, serving as chief resident. An international lecturer and published researcher, Dr. Mish is known for his expertise in implantology, advanced bone augmentation, and peri-implant tissue stability. Tonight, he's going to share some insights on achieving tissue stability through innovative socket shield techniques and surgical guides. And before I say welcome, I just want to let you know there is a Q&A box. Please blast it, fill it up. I will interrupt my friend, Dr. John, here anytime with questions. He does not mind. I promise you that big smirk and grin on his face means that he's agreeing to that. So without further ado, you don't want to hear from me. Please help me welcome Dr. Jonathan Mish. Welcome, buddy.
Thank you so much, Greg. And really, I want to say thank you to you, Greg, but also just to 3D Diagnostics for hosting this webinar and having me today, and for your support, not only here, but also with the Mish Institute, and also to all the vendors that are here, BioHorizons, Vulcan, Power Dental, CareStream Dental. Thank you so much for your support. And also, I just want to say to everybody, the reason that we reached out to these companies in particular is because I use these on a regular basis in my clinical practice. And I've found each one of these to really be important to the daily things that I'm doing and the cases that I'm doing. So you'll be seeing each of them kind of highlighted throughout the presentation and how I use them in my practice, just so you can kind of get an idea if that's something that you would also find helpful to you. Yeah, and also just as Greg mentioned, please feel free to interrupt and ask questions during the presentation. This is the same thing that we do at the Institute. It's a very much open format. So we have lecturers that are, obviously world renowned and some of the top in the field at what they're talking about. And every single one of their lectures and my lectures is made so that we are trying to instigate conversation. And that's really how everybody learns the most. So please ask questions. Feel free to try to stump me if you want. I love that type of stuff. So yeah, and with that, I'll just get going. So just to introduce myself, again, very briefly, I know Greg already kind of did, but my name is Jonathan Mish. I'm from Canton, Michigan, graduated from U of M, unfortunately, for my DDS and my master's in periodontics. I'm in private practice in Pinckney, Michigan, and I'm the CEO of the Mish Implant Institute, which was originally started by my father back in 1984. Just two quick, interesting, kind of like funny things. If you Google me, there's two things that you're going to see. One of them is you'll find out that I'm a terrible tackler, and that I had a lot of really good players just kind of blow through me. Here's a photo of Mark Ingram. I'm number 36 behind him. So this is why I said it's unfortunate I went to U of M, because I played football for Michigan State. Mark Ingram literally made me, like, I couldn't feel my shoulder after one of the times he hit me. This is Trent Richardson. I don't really know what I'm doing in this photo. I think it kind of looks like I'm just crying because I think they beat us by like 40 something points. And that is a terrible tackle. And then Calvin Grady, not only am I a bad tackler, I'm also very slow because the Calvin Grady just, ran right past me without really any trouble. The other thing that actually my patients find really funny when they Google who are they going to be having work done with, they always ask, why do you have so many photos of you with your shirt off online? And that's because my wife and I were on Survivor together back in 2014 now, season 29. And I always just like to follow that with, the starvation is real, guys. That is a photo of me on day, I think 36. I lost 35 pounds in 36 days. And yeah, that is it's not, that part's not fun. So that's not why we're here today, though. Today we're here to talk about going beyond the pros concepts. I know Greg was saying pros, but you'll see why I say pros in just a second. And improving tissue stability with socket shielding and surgical guides. So before we jump into the socket shielding surgical guides, we need to know what the pros concepts are in case you're not familiar. And I know everybody knows this saying, the bone sets the tone, but the tissue is the issue. But we all know, even a periodontist will admit, pros is the boss. And that's really why I know it's spelled pros, but we pronounce it pros because this is an acronym that really is a recipe for success in our implant placements and really achieving optimal tissue stability. As I said, this, oh, I'm sorry, I didn't mention. So this was published just recently in the International Journal of Oral Implantology. And anytime that you publish something, you really hope that it's gonna blow up and everybody is just gonna be talking about your article and everything, and rarely ever actually happens, right? But this, I'm very excited to see the response that we got here. It is a very popular article right now, and I'm seeing people lecturing on it in all over the world, actually, people in Singapore, Kuwait, California, Boston, Mexico, Texas, I've seen getting tagged kind of all over the place. And actually, because of this article, I've even had some of really who I consider some of my my idols in the field reach out to me and start really interacting to start to do some things together. So it's been a very exciting time. And I only say that to allow you guys to understand that this isn't just a periodontist's idea of what he thinks works. This is really agreed upon around the world. And this isn't anything groundbreaking. I didn't do anything extremely special and identify something insane by writing the pros concepts. Because all we did, all that the article is we recognized that these were what people were doing and having the most success with, and that the literature really backed up all of these, each one of these letters in the acronym. And what these stand for is platform switching, is the P. R is for restorative design. O is for optimal connection. And S is for subcrestal placement. And when we combine all these things together, as you'll see, you can really have some very stable bone levels and really achieve the highest bone levels on your implants. So just as a very, very quick overview, I have a 2-hour lecture on this, but we're gonna do it in about 3 minutes. So platform switching, one slide just to say, a lot of systematic reviews. I think everybody knows by now, platform switching is something that really helps our bone levels on our implants. If you're not familiar with what that is, that's when the platform of the abutment is more narrow than the platform of, or the diameter of the dental implant. And that just moves the micro movements of the superstructure inward so that it's not impacting the marginal bone. Our restorative design is summarized very well by saying we need to follow aesthetic biological contour concepts. This is an article that was published by Gomez Meda, Jonathan Esquivel, and Marcus Blatz in 2023. And this is really our updated critical and subcritical contours. And these are the EBCs, we call them. And these stand for 3 separate zones, just like critical and subcritical contours were 2 zones. The aesthetic, bounded, and crestal zones are now the 3 zones that we break our superstructure into. And when we look at these, the aesthetic zone is that first millimeter underneath the free mucosal margin, where this is the critical zone that Sue published in 2010, I believe. And this is the shape of this is going to influence our mucosal margins. And the position of it is going to determine where that margin is. The crestal zone, we know now this needs to be straight or concave for at least 1 to 1.5 millimeters above the platform of the implant. This is space for those crestal tissues. And really, even if you're placing subcrestally, you should actually be looking at the bone crest as your baseline rather than the platform of the implant, so that we can really allow the bone some space and allow the tissues some space to have stability, and that will limit our bone loss on our implants. The bounded zone is bounded by the E, the aesthetic zone, and the crestal zone. And this really is more space for connective tissue. We want this to be either concave. In some thick phenotype patients, we can have this be straight depending on the case and what we're trying to do. But this article, if you haven't read it, Aesthetic Biological Contour Concepts, this is, in my mind, like if there's one article that I'm going to try and memorize, it's the EVCs. The O, P-R-O-S, the O is for optimal connection, as I mentioned. And when we say optimal connection, we're talking about a conical connection. And when we look at systematic reviews and meta-analyses like this one that was done by Camp Fonts, time and time again, what you're going to see, conical connections have less marginal bone loss than internal hex and external hex implants. But also what we find is that we also have better implant survival. We have fewer prosthetic complications and that less marginal bone loss. And in my longer lecture, I talk about the influence of marginal bone loss on disease and all of those things and how conical connection can improve that. But really, this is what is ideal right now, this connection. And when we have a conical connection, we should also be very specifically looking for a deep conical connection, because not all connections are made equally. And this is very, very obvious in the literature. And I just want to say before I show the next slide, for a long time, my interest in my research and my residency was on prosthetic designs and their influence on marginal bone loss and disease. And so connection type was something that I was always kind of nerded out about. And I had always been like obsessed with the cone log, cam log connection, their deep conical connection. So when BioHorizons acquired cone log, a year or two years ago, and they took that connection and put it into their implant. I think there were 3 great days in my life. The day I got married, the day my son Logan was born, the third was the day BioHorizons got this deep conical connection. That is how excited I was about this, okay? I like almost threw a party. So when we look at this connection and we kind of compare it across the board, I'm not here to call out other companies, but when we look at the stability of this connection, is very, very obvious according to the literature that this is the most stable connection that we have. And one of the factors on an implant that really impacts marginal bone levels the most, and that we have very strong evidence to show, is connection and the stability of the superstructure. So that's one of the reasons I love the BioHorizons implant, and that's why you'll see me placing those in all my cases. Subcrestal placement, I got to be brief here because we got a lot to go here. But just to say this article really summarizes not only subcrestal placement, but the pros concepts in general. Randomized control trial by Stacky. They had over 100 implants that they placed, either 1 millimeter or 2 millimeters subcrestal, and they followed the pros concepts. They had platform switching, conical connections, and they had abutments of more than 2 millimeters. They actually followed one abutment one time also. And what they found when they looked at things, you can see here at the time of implant placement, which is A, to the time that the restoration was put on, B, to the time 1 year later, C, marginal bone levels are all above the level of the platform. And that's not just like they found the best x-rays and showed it in this one x-ray. 95%, and there's over 100 implants here, 95% of the implants had bone levels above the level of the platform on these implants. And when you look at the 1 millimeter subcrestal group versus the 2 millimeter subcrestal group, I mean, basically both of them worked very well. I don't want to get into the weeds of it, but subcrestal placement combined with the pros concepts, PROS, really seems to be something that can achieve optimal bone levels on our implants. So today, we're going to be going through this case in particular. You're going to be seeing a lot of videos from this case from different angles, and we're going to be talking through every step of a case where I'm doing an immediate implant with a socket shield using a surgical guide, and we're going to be answering the questions for each one of the decisions that we need to make and looking at the literature behind those decisions that we're making. And you'll understand more about what I mean by that in just a minute here. So before we start the surgery, we obviously need to plan for the surgery. And this is just to say my sequence of events. I'm taking you through my surgery, my case from start to finish. So first thing I do, I always get a CBCT. I have a Carestream in my office. I have a Carestream 9600. And one thing that first off, I liked Carestream from the beginning just because it was really an intuitive design. I didn't need training to understand how to use it. But also once I started using it and really understanding how important some of the factors are, for example, their voxel size, which is how small basically you can see a structure, is around 75 microns. So you saw me there, I can measure a buccal plate. In some CBCTs, they're not accurate enough where you can actually measure a buccal plate. Tracing nerve canals, placing implants in here, it's all really just kind of easy to do. So I always use a Carestream. We have Carestream at the Institute as well, and most of our faculty use Carestreams as well. So just to say, that's my first step, get the CBCT, evaluate, and plan from there. I then typically upload that with an intraoral scan to 3D Diagnostics. This is me signing into my account. Those are all the patients that I've done with them in the past and blocking out their names. Well, they showed for a second there. Don't tell anyone. Selecting that I want a surgical guide. I also just would like to mention that they do radiology reports. And this is, I think it's $80 for 24-hour turnaround. If there's nothing else that you could use, that is something that every CBCT really needs. And I think it's the only one that I found that does a 24-hour turnaround. So putting the patient's name in there, selecting that I'm doing an immediate implant. Number 9 is to be extracted and is where I'm placing the implant at. I go over to the treatment plan, and basically I'm saying I'm doing BioHorizons tapered proconical, planning for a single implant restoration, FP1, planning an immediate implant, and just follow the prompts here. And then it's uploaded. And when I have a case like this where I'm planning a socket shield, I also check down here on the left, schedule a fine-tuning session so that I can meet with the doctor and just make sure that everything was planned the same way that I would like. So in this case, I'm doing an immediate load. They also are able to print provisionals. So I'm meeting with a prosthetist here who has already designed the provisional for me. It's just all I have to do is kind of confirm with them. They're doctors, so 99% of the time I don't have anything really to change. I'm just, yeah, okay, that looks good. Sometimes there's things that I specifically like, but in general, these implants are planned very well. But you can see, I mean, this takes all of the planning work out of my hands. So I don't need to train myself on exocad to be able to print a provisional for my immediate implant here. I've already done that here. So that fits very well in the way that I do things. This is just to show that that's not me doing this. This is a screen recording from my Zoom that I had with the doctors that were planning this provisional for me. So these are 9 steps that we're going to go through and decisions that we need to make during surgery. Some of these I'm going to fire through because there's certain things that I believe you really want to hear about today, namely some socket shielding and surgical guides, and others we'll spend a little bit of time on. So first question, are we going to be doing flap or flapless during this procedure? My computer is going nice and slow right now, so I have clicked, but it's giving me a spinning wheel. So if this... Hopefully that's not an indication of how the rest of this is going to go. So in this systematic review and network meta-analysis, they're looking at buccal bone thickness and midfacial recession after various procedures with immediate implant. So flapless, grafting the gap. So basically doing socket preservation with the immediate implant, soft tissue grafting, all of those things. And when we look at the results of this study, what we find is that the buccal bone thickness reduction was the least in the group that was flapless with hard tissue augmentation. So flapless, and they grafted the gap. They added bone grafting to the space between the implant and the buccal plate. So I think we all kind of know by now, when we can do flapless, we're going to go flapless, but you need to do it in select cases. If you do it in the wrong case, you can really cause some problems. So, but ideally, an immediate implant, especially with socket shield, we're going to be doing this flapless, and that's going to save, in this case, about 0.8 millimeters, almost a full millimeter of buccal bone thickness compared to flap opening. So in this, that's why we see I'm using a 15C blade. I'm being very diligent to just preserve all the tissues that I can. I'm reaching all the way into proximally, going down to bone, severing all of these dentogingival fibers so that I'm not causing any trauma to this. I'm limiting as much as possible the trauma that this site is going through, and I'm not elevating a flap on the buccal aspect of here. If I am going to, the way that I would choose to do that would be to tunnel it so that I have the best flap adaptation and my flap has best tissue perfusion through the papillas and all that. That's my personal choice. There are other ways to do that, obviously, then, and there's good reasons for it. So we're going to be doing this flapless based on the literature that we just looked at. Come on. Getting the spinning wheel here again, guys. I don't know if you guys can see my mouse, but again, hopefully this goes
no worries.
a little smooth.
We did have a little something from the Q&A, and it's from our friend Boyd Peters over at BioHorizons, and he just like
Hey,
to
Boyd,
say
how's it going?
he just wanted to say roll tide.
Oh, come on, man. Yeah, appreciate it. Thanks very much for your support, Boyd.
So back to our
awesome.
regularly scheduled program.
All right, sounds good. So, okay, the next thing we're going to talk about is extraction technique. Obviously, we know that we want this to be minimally traumatic. So what is the least traumatic way that we can extract a tooth? Well, if we're not doing socket shielding, the least traumatic way for an anterior tooth, at least, is to use a forceps and deliver that tooth all in one piece, because that limits the amount of cutting and trauma that we have to do to any of the tissues in that area. If it's a posterior tooth, maybe that would include sectioning that root, so we're not expanding the alveolus as we're getting that tooth through the socket. But anterior teeth, typically, we can deliver them fairly well with going straight to a forceps. If that's not possible, we may need to section our root. And when we're sectioning, I always say create space, elevate, and deliver. And that's what we see when we're doing here. And in this video, there's two things that I like to point out that I use in pretty much every extraction that I do, which one of them is the long burr that you'll be seeing, and the other are these twist elevators. And I'm gonna maybe get through this a little bit, so hopefully this will, yeah, there we go.
So we do have a question from a doctor too, Jonathan. If you want me to wait, I can. It's from an anonymous attendee. It says, what's the name of the software service that you used with CareStream for the prosthetic design?
For prosthetic design, so that is the video that you saw was a screen recording from my meeting with 3D Diagnostics. They designed the crown. They designed it with ExoCAD. But me personally, I don't design my provisionals. I let people who know more on digital design provisionals for me.
But that was our team. I just wanted to make sure you got to answer that while we were right on that spot. Yeah, of course, please.
Yeah, thank you very much. In another video here in a second, I'm going to have a little thing you can take a photo of. What's the name where you take a photo of it and it goes to the website where you can
screenshot or QR code. There you go.
QR code. There you go. I'll have a QR code for this burr, because I feel like a good sectioning burr is very, very hard to come by. But here I'm also going to show you guys a QR code for these twist elevators, because I use these on every single extraction. That is not an exaggeration. They are my fail safe every time I'm sectioning a tooth. Even today I was doing wisdom teeth. These are the instrument that get the root out for me. And it's just, they've got a very small tip that can be rotated and twisted into the PDL. And that twisting inside the socket gives for some really nice angular pressure on these roots to make these very easy to remove. So I just wanted to show that really quickly. If we're going to be doing a socket shield, rather than splitting this tooth into mesial and distal sections, as you just saw in that video, we're going to be splitting it into buccal and palatal sections, right? And there's two ways that we can do this. One of them I'm going to show you later. The other is going to be in this video here, where we're making a C-shaped buccal shield. A C-shaped shield is going to be from line angle to line angle. It's not going to extend into the interproximal zones. And typically we would do this when we're not trying, like let's say we don't have an implant adjacent. We don't then necessarily need to extend those shields into the interproximal zones to maintain those papilla, because the adjacent tooth will. But you may choose to do that even from this point, just in case something happens to the adjacent tooth. So not necessarily a wrong way to choose there. But there I section into buccal lingual halves, and now I'm taking that long sectioning burr, and I'm continuing all the way down to the apex. And as you'll see here, you can actually see the root canal there, and I'm actually facial to the canal down there. I'm about halfway through the root, a little bit further than halfway through the root. And at this point, I'm moving toward the facial so that I can remove my apex in one piece with my palatal root fragment. And that's really makes it ideal so that you're removing the entire apex, which is very important when we're doing socket shielding technique. The other thing that you saw that I was doing there, I took that burr and I ran it along the palatal wall, more crown prepping the root than removing bone structure. But what I'm doing is I'm making a very small space so that I can take my twist elevator and I rotate it into that space. And that just actually pries that palatal fragment off the palatal wall. And this works for me every single time. It is a very, as I said, I use those in every single extraction, but especially when I'm sectioning the roots, such as when I'm doing socket shielding. So there on the left is the twist elevators that I was just using. And on the right is for that sectioning burr. I'm gonna give you guys just a second if you wanna take a photo of that with your phone. If you miss it, let me know later. I'm happy to come back to the slide and show you guys. So moving to our next step here, we are now deciding between, come on, man. It's always, you know, I got to get a better laptop here because my RAM is too low, I guess. All these videos are slowing it down. It's never done this, all the times that I've gone through this. Come on, I clicked it already. Any other questions that I can answer while I'm stalling?
We do, and thank you for asking. This is from Dr. Laszlo. Could you describe the end anatomy of the prep cut done on coronal aspect of the socket shield?
I'm going to get into that more. So I think you're referring to how high is my shield, and in respect to the free mucosal margin and the bone crest. If that's not what you mean, please put that question back into there, and I'll make sure to address your question. But if that is what you mean, I'll be addressing it in a little bit, so we'll get to it. So before getting further into socket shielding, I want to make sure everybody understands there is a difference between partial extraction and socket shield. Partial extraction is basically our umbrella term. It is anything where we are going to leave a fragment of the root in the alveolus, whereas socket shielding is just one partial extraction therapy. So it's under the umbrella of a partial extraction. Partial extractions can be root banking, pontic shields, socket shields, root T-belt. All those are partial extractions. Socket shielding is just socket shielding. So today we're talking about socket shielding. Indications for this, I took this from the Gluckman article. I'm going to add a couple to this because really what this is saying is pretty much the indications are the tooth needs to be extracted for one reason or another. It's indicated for extraction. It can have apical pathology or no apical pathology as long as you can remove all of the apical pathology, similar to our rule with immediate implants. Immediate provisionals are ideal, or at least a custom healer. And you can do this if a root has resorption. You just want to make sure that that resorption is not included in the fragment that you're keeping for your shield. And yes, intention to preserve the ridge contour or papillas are definitely reasons that we would do a socket shield or a proximal shield. Contraindications would be if we have a deep fracture involving the buccal plate, extensive bony dehiscence, mobile socket shields, especially mobile socket shields, that can lead to some complications in the future. Apically ankylosed teeth. So a tooth has ankylosis that is now apical, and we have a more apically positioned free gingival margin. We don't want to be doing socket shielding on that case. Deep residual perio defects are contraindicated, and really extensive periapical pathology that are too extensive for us to remove. So let's look at, this is a systematic review on longitudinal studies that was done by Katsakis. Really great study here that was published in 2022, I believe. They had 10 human studies were included, had over 500 patients, almost 600 implants, and they, also performed a meta-analysis of 3 randomized control trials. And what they found when they looked at all the results, they found almost 2 times less marginal bone loss versus conventional immediate, a very comparable success rates, reduced incidence of recession on those socket shielding cases, and a stable Pink Aesthetic Score versus baseline. And what that means, if you're not familiar with Pink Aesthetic Score, PES is basically a rating or a gauge of how great the soft tissue looks at that time. So you're grading recession, papilla height, all of these things, contours, all that type of stuff. So to say that it's got a stable Pink Aesthetic Score compared to baseline is to say that we couldn't tell the difference from when the tooth was in health versus an implant later, which is really something that's probably the best thing that we can say about socket shielding, is that it preserves that Pink Aesthetic Score. This is just another systematic review that shows gingival margin stability is improved, papilla height preservation improved, especially when we have adjacent implants, buccal bone and contour preservation, marginal bone preservation, all reported in multiple systematic reviews. This is why this lines up with the PROS concept so much, and why I included PROS in this lecture, because PROS concepts they're not just about the acronym platform switch, restorative design, optimal connection, subcrestal placement. Each of these factors provide some form of stability to the tissues and really improve and increase space for tissues. When we have platform switching, we're bringing the abutment inward, giving more space for tissues. Having good restorative design, we're keeping a crestal zone of straight or concave to really keep space for tissues. Optimal connection, we're limiting micro movements that are going to impact tissues. Subcrestal placement, we're actually positioning the platform of our implant below the level of where bones forming cells can permeate, so we have the potential for bone formation above the platform, so more space for tissues. So socket shielding is something that really is in line with PROS concepts because it allows us to preserve our tissues. And the way I like to say it is, I like things that will preserve biology, not make room for technology. So I'm a biologist, I'm not a technologist. That's really what PROS concepts are all about. When we look histologically at what's happening with socket shield, this is the study from Marcus Herzler, his proof of concept study. They did some histology, and what they saw was that not only are we maintaining that buccal plate, which is so important, immediate implants, remember, in the anterior, average buccal plate thickness is around 0.6 millimeters. And the research shown by Araujo, what that shows us is that that is entirely bundle bone. Bundle bone means that is more like PDL than it is like bone. So as soon as that root fragment is removed, the bundle bone no longer has a reason to be there. Its loss of function causes it to be resorbed. So when we have an anterior tooth that's indicated for extraction, very likely we're going to have only bundle bone on that aspect. This maintains that buccal plate. Socket shielding maintains the buccal plate. Also, what we see is implant to shield ankylosis, and really you can see that very well in these two studies. The one on the right was the proof of concept study. He actually used M-Degain on the internal surface of the shield, and what they found was that we had some mineralized tissue formation in the space between the implant and the shield, but where the shield was contacting the implant, we had resorption of the shield and replacement with new cementum. But in the Baumer study in 2013, they did not use M-Degain, and what they saw was just ankylosis, bony ankylosis, and mineralized tissue formation. So that's what we're seeing histologically. We do see bone formation, we see cementum formation. Which one's more ideal? I don't think we have the information to really say one versus the other, but we do see hard tissue formation between the implant and the shield. If you've never done a socket shield, this is going to be the first thing that you need to do. You need to open this article up, screenshot this, make sure you find this article, read this article, because this goes step by step how to perform the socket shield based on all of the things that they've learned over the 10 years that they were doing it before they did this. We've been doing it for about 15 years now, but at this time, 10 years. So great article for you if you have not read this. I really, really recommend it. It will go into everything. If you have an endodontic post in there, how you manage that and how you still do a shield with that. If there's no post, how to section the root, apex management, how you remove the apex, coronal root preparation, so answering that question that we just had a little bit ago, implant placement, location, and management of the gap, all of those things are covered in that article. I'm going to talk through those one by one right now. So in this video, we already saw a portion of this, where I was sectioning this root. I'm really making sure that I'm looking down the socket in this case, because next you'll see how to do this with a guide. But here I don't have a guide. So I'm seeing my root canal. I want to preserve at least 1/3 to 1/2 of the coronal aspect of my root. That's the ideal for how much of that root we're keeping. So I like a longer shield, so I'm shooting for at least half of my root length to be maintained on the buccal aspect. So when I'm down at that apical aspect, I'm removing the facial after I've already gone beyond halfway down the root, right? Or I'm removing the apex after I'm already halfway down the root. We already watched this portion, so I'm going to kind of skip through. Eventually, I get that little bugger out, and now we start to shape our shield. So ideally, we want to reduce this shield till it's about 1.5 millimeters thick. Some people like it a little thicker than that. Some people like it thinner. I like 1.5 millimeters because it's thick enough where I'm not worried about this being a brittle shield, and I'm not worried about it breaking on me. And I also have a little bit of space for my implant. I personally don't like to engage my shield. I'll get into that later, but that's just my decision, okay? Then I'm going to start reducing the height of my shield. There are socket shielding kits that you guys can use. I don't use them in my practice, but you can use them. I've heard that they can be helpful, but I don't use them. I just use my, as you can see there, those are my Power Dental instruments, actually. That blue periosteal elevator was from Power Dental. So I just use that to kind of protect my gingival margin. Here I'm bone sounding, so I take a probe and I bone sound to measure how much more do I need to remove of my shield that's above the buccal plate. We want our shield to be flush with the buccal plate. The first way that we were doing socket shielding, we were allowing 1 millimeter of the root, the shield, to be above the buccal plate. Now what we found is that increases the incidence of internal exposures where you actually see the root. If you remove the crown, you see the root on the inside. That can also cause some other complications. But so now we put it flush with the buccal plate, and that's what I'm doing here. So I protect my gingival margin with my probe, as you were seeing there. I'm actually protecting my gingival margin, but I'm also bone sounding as I'm doing that. And I'm removing, in this case, I'm using the round burr. I usually use an end cutting burr, but I'm removing everything above that buccal plate. And as soon as I remove it, you'll see my probe kind of fall into the socket. So I'm pressuring toward the socket so that I know as soon as I've removed everything above the buccal plate, my probe can go freely. And then I continue down the line and I remove everything. Finally, what we do, smooth out the internal surface of the shield, and we bevel the coronal 2 millimeters so that we have a nice chamfer going down from the most coronal aspect of our shield downward for 2 millimeters. That's what it looks like on the inside. Also want to inspect that shield, make sure if you had a root canal in there, you remove any fragments of gutta percha, anything like that. And this is what we look like. Very atraumatic, tissues completely preserved. Here, I would say if I'm critiquing myself, I think my shield's a little bit thin on the thin side in this case, but it should be totally fine. It's immobile, and we're gonna have, we're set up very well here. In another case, this actually was my mother-in-law. I saw her just Saturday, this Saturday that just passed. And I did everything I could to try to document and get it so that I could show you guys. But in her case, one day, all of a sudden, number 9 was moving. You can see here, I'm barely even touching the tooth, and the crown is about to come off. So what I did in this case, I told 3D Diagnostics, make me a sectioning guide. And you're going to see what that does for us. But what I'm doing here, I'm reducing with a burr, I'm reducing the height of the root fragment that's remaining so that I can actually fit on here my guide. And my guide has been made so that I use a pin to go directly down to the apex of the root. And that means that I know I'm removing all of my apex of my root, and I am very, very guided with exactly how thick my shield is on the facial. And this just really makes this very, very predictable. In this case, I'm doing a U-shaped shield. So I'm actually extending into the interproximal zones. Reason I did that in her case is because her adjacent tooth has a root canal. And if something goes wrong with that tooth, I want to make sure that I have preservation of this papilla height if she needs another implant on the adjacent root. That right there, you can see it is what our shield looks like after I've only sectioned my root, but that's how I'm sectioning it into this U. We remove the palatal aspect in one piece, then we can start shaping our shield again. And I'm going down the root, I'm reducing the thickness from coronal down to the apex. And in this case, since it's guided, I know I've removed the entire apical zone of my root canal, so I'm actually able to save much more of my buccal fragment, and I can have a longer shield. And that's how I like it. That's how, if you're familiar with Dr. Gluckman, that's how Gluckman likes it as well, as a longer shield. So that's what ideally we would do. Here now, I'm bone sounding again, and I follow the same pattern that we saw before. In this case, I use an end cutting burr, and as I said, bone sounding until it falls into the socket. And then I use my round burr to do my chamfer or my bevel of those most coronal 2 millimeters of the shield. That's the guide that 3D Diagnostics gave me. The BioHorizons Taper Pro Conical, the 3.3, is a 2.4 millimeter apex. So I only use the first burr. It's a 2.5 millimeter burr, and that allows me to get some really good stability on these implants. So that's what we have right there. That's the space that I have on my shield, and that's where I ended up there. So that's socket shielding versus traditional. So let's jump into, do we need a guide? Come on, baby. And with 3D Diagnostics here and Vulcan here, I think both of them are pretty hopeful that the verdict is going to be, yeah, we should probably use a guide. So spoiler alert, the answer is yes, we should probably be using a guide, guys. So let's look at some of the evidence as to why. I'm going to try to fire through here as fast as my slides will let me. This is just to say, this is how I feel. The last slide, that's how I feel anytime I don't have a guide today, because I pretty much do all of my cases guided. So when I don't, I feel like you're going into the surgery blind. You don't really know exactly how things are going to go sometimes. And that, when we look at the literature comparing freehand versus fully guided, or even just pilot guided, it actually really supports that idea. You look at these numbers, coronal lateral deviation. So at the platform, how much deviation do I have laterally? Or at the apex, how much deviation do I have laterally? These are in millimeters. 1.92 millimeters apically of deviation compared to where you're planning. Like, how many roots am I hitting if I'm freehanding and I have a 2 millimeter error? 1.5 millimeters at the coronal. That is the difference between having a nice buccal plate thickness or having a recession in 3 years after the soft tissue has remodeled and everything. And so that is a huge variation. Whereas fully guided, we're seeing down less than 1 millimeter, half a millimeter, less than a millimeter down at the apex. So that's coronal lateral, coronal global, and apical global. That's horizontal and vertical deviation. Those numbers are even more staggering, honestly, in my opinion. So guided, obviously, we know is much more accurate. With immediate implants, that's even more important, because we have this added difficulty of the fact that we have not only more dense bone on the palate, but we have no bone in the socket. So our implant, even when we have an osteotomy that's perfect, is going to drift facially when we're placing that implant into the socket. Guides end up resisting that more than freehand, actually, but even guides are impacted by this. So when I'm doing a guided immediate implant placement, I actually end up planning to have that implant in my plan with my guide. I have that slightly more palatal at the coronal aspect than would be ideal, knowing that this implant is going to be very, very slightly less than a millimeter drifted toward the facial. When we look at impacts of clinically impactful incidents when we're looking freehanded in this study by one of my co-residents, Dr. Zhao Chen, freehand implant placement, 37% of the time we're invading the incisive canal, 12% when we did it with a guide. 25% of the time we have apical buccal bone penetration when we're freehand, 8% when we're guided. In total, about 50% of the time, there is something that could be clinically impactful when we're doing freehand, whereas guided 16% of the time. So much, much less often. And again, guys, You don't have to go and train yourself how to use co-diagnostics. I know how to use co-diagnostics, but this is not me using co-diagnostics. This is Dr. Paul using co-diagnostics. I don't want to take my time away from my son, and I got an institute to run. I got a wife to keep happy. I got a son to raise. I got a practice to run. Planning cases is not something that I want to put my time on. So they plan it. I spend about 5 minutes with them. We did actually 5 cases we looked at here. On average, we spent 4 minutes per case, just saying, yep, that looks good, change the length of that, make that a little bit more apical, whatever. 4 minutes per case. So it's not like we need to add an hour of planning. And when we look at reviews at the pros and cons of guided implant placement, this is what we see: significantly less surgical time, more predictable outcomes, but the time involved in planning takes away from your profit margin. So don't plan. Have somebody else plan it. Use 3D Diagnostics. They'll plan it for you, and then you don't have to worry about anything. And then you can have all the benefits of guided without any of the cons. So moving from guided, the next thing we're going to talk about, again, if my computer will let me, I'm trying to hit that 45-minute mark, Greg, but you know, give me a little bit of leeway because my computer's stalling on me. It's the computer's fault, not mine.
I will show grace, unlike those running backs who ran over you that you showed at the very beginning of your presentation. Please continue.
I'm still icing my shoulder, man.
You showed grace to me saying pros instead of pros, so there's grace all the way around, and I'm sure all the attendees are loving what you're sharing, so please.
Yeah, I hope so. Okay, so we're going to talk about implant positioning and provisional design, okay? So this video here, as I said, this is the prosthodontist that I was meeting with 3D Diagnostics for this case that I was doing. They actually are planning the implant positioning based, they know I'm doing a socket shield. So they're placing it more palatal. I told them I like to have space. I don't personally like to engage my plate because I feel like that runs the risk of dislodging the socket shield. And I know some very good clinicians, Hersler and some other very, very big names, they engage the plate and it's called mechanical locking. It's something you can do, especially if you're placing guided, but I personally like to have a little bit of space for tissues to fill in. So they are measuring, they're saying, okay, yep, I'm giving 2 millimeters in this case so that I have 1.5 millimeters for my shield and at least 0.5 millimeter of space for space between the shield and my implant. They're also measuring from the shield to the prosthetic so that they can see that there's at least 2 millimeters in that area so we don't have internal shield exposures. So that's where we're positioning our implant. We're positioning it in a way, as I said, you can engage the shield, but I like to have 0.5, at least 0.5 millimeters of space, 0.5 to 1 is ideal for me, of space open between my shield and my implant to allow for tissues to fill in. Provisional design. The same guys, two of the same guys, Jonathan Escabel and Ramon Gomez-Meda, published this article, which I absolutely love. Another one, take a photo of this. This really goes through how you make your decision-making for how to design your provisional and the timing of when you replace it and how the design of those should be, okay? So you can have fully contoured, sub-contoured provisionals, or you can have margin preservation therapy or margin reestablishment therapy. Fully contoured provisional, very self-explanatory. It is the final restoration. It's the ideal shape with a zenith that corresponds to the final restoration. You can have active fully contoured or passive fully contoured. Active is putting pressure on tissues. So if I have a coronally displaced margin and I want it to drift apically, I'm going to have an active fully contoured provisional and it's going to drift my tissues more apically. Passive, I'm not putting any pressure. They're already ideal. Subcontoured provisionals is what you'll see in the case when we see the final video. The E zone is going to be 2 millimeters coronal to the ideal point so that we have more space for soft tissue fill. B zone is very concave, and the C zone is straight and as slim as you can be without causing fracture of the provisional material. With margin preservation therapy, we have ideal tissues positioning and thick phenotypes. Margin reestablishment, we're trying to reestablish where the margin is. So we have a margin that's apical to ideal. we're grafting maybe due to thin phenotypes, or possibly we have some minor dehiscences. So in these margin reestablishment therapy, MRTs, we start with a type 2 subcontoured provisional, and then we transition them to a fully contoured provisional. If it's soft tissue grafting only, we wait 2 months, then we can transition to our final contoured provisional. If it's hard tissue grafting, depending on how large the grafting is, if it's very minor, just wait for osseointegration, 4 months or so. If it's more severe, 6 months up to 12 months even. So that's how we gauge when we're doing that. And just one more note to say, I mentioned this before, at least 1.5 to 2 millimeters, ideally 2 millimeters of space from our provisional to where our shield is. That's going to reduce how often we have internal shield exposures where we can see the root through our soft tissue if we were to remove our crown. That also can cause some inflammation and redness, so we don't want that, or erythema. So moving on from there, just 2 more, 3 more. Well, the next one is very, very quick, I believe. One of them is very, very quick. I better be very, very quick because I'm already over my time. Are we going to graft the gap? The answer I'm going to tell you right now is yes. We look at the effect of grafting the gap with immediate implants without socket shielding, for example. No, when you have a gap, ideally we want it to be 2 millimeters. And when we graft those gaps after healing, we have significantly thicker buccal bone, which means significantly more stable buccal bone. In this case, you can see I have a little bit of a gap between my shield and my implant. Am I going to graft this? There are reports of both grafting them and not grafting them. The vast majority have been grafting the gap, but there are reports of success when we leave this open. I personally am going to place a graft in there because I like what that does for clot stability and volume preservation. But even without that, I know my shield is preserving that volume and I have a very stable implant. So we do theoretically have a stable clot, a stable space, closure in the area. So really all those past principles that we need for bone formation, they're already present in this socket. So that's what I'd say there. So that's what we do for grafting the gap. Getting the spinning wheel again. Come on, guys. Any questions while I'm getting the spinning wheel, Greg?
I've got nothing other than, will the Detroit Lions make it to the Super Bowl finally this year after the 54 years that I've struggled? They have not seen the promised land, let alone win.
I really, really hope so. We've had too many days that we're getting, or too many seasons.
Well, that's the question that I had for you.
That's a good one. I do see a couple of hand raises. I am still getting.
I do. I have a hand raise from Henry Bunch, and it's dicey to let him raise their hand and actually speak, but I'm going to do it. I'm going to allow him to talk.
Go ahead,
Dr. Henry Bunch. Let's do it. Go for it. Go for it, Henry. You can unmute.
I think you're still muted, Henry. If you want to unmute yourself, you can ask your question. But if that was an accident, then
it could have been. It might have been up from before. All right. Why don't you continue? And,
okay. I'm going to continue here. Yeah. Sorry, guys.
You got it. Yep. Go ahead and let's continue on. Thanks.
Okay. So are we going to calf or are we going to tunnel? This is what I'm going to say. So when you listen to all the experts, they'll tell you that when we're doing socket shielding, you don't want to remove the tissue from that buccal plate because that will instigate remodeling of the buccal plate. You're going to see in my case that I actually do a connective tissue graft with my socket shield in this particular case that I'm showing. It's not necessary unless you're looking for margin reestablishment therapy and coronally advancing tissues. So that's just a note to say that. So calf versus tunnel, which one is better? In this study by Zur, he showed that tunneling resulted in significantly better clinical outcomes compared to calf. In this study by Ozinchi, better clinical results were achieved with calf versus tunnel. So really what we find when we look at all the literature, Both techniques have similar efficacy. What we know is that it depends on the clinician. So if you have experience with tunneling, you can do a lot of things that somebody who doesn't have experience with tunneling can do. If you only have experience with CAF, coronally advanced flaps, you can do things better than somebody that doesn't. So it depends on what you personally like to do for your cases. I tend to opt for tunneling, but in some cases, especially with more severe recessions, for especially natural teeth, I'll opt for coronally advancing flaps. So finally, we're going to talk very briefly about soft tissue grafting techniques for harvesting, and I'll talk about my specific technique for how I harvest my soft tissue grafts. This is an article a lot of people are familiar with, and we at U of M are, we always love to show because Dr. Tavelli graduated from U of M, and he's over at Harvard now blowing things up, just an amazing clinician and researcher. I actually love saying I assisted him when he was a resident because it was like, man, I knew that guy before he was Tavelli, you know, but a great human being, phenomenal researcher, and great clinician. So this tells us how far away our artery is from our CEJ. But rather than just memorizing 13.9, 13, 13.8, 11.8, 9.9, all those things like you need to do if you're in a residency, what you should really understand by looking at this is as we move anteriorly, the artery gets closer to the CEJ, but also the artery gets less large. It gets, the diameter shrinks. So if you nick it in the premolar or in the canine region, it's much less severe than if you nick it back in the molar region. Even so, if you do nick it, it's very easily managed with some techniques. More clinically applicable, I would say, is this article by Reiser, where he showed that depending on the depth of the palate, that artery is going to move upward with the depth. So in a shallow palate, it's going to be around 7 millimeters, average palate around 12 millimeters, high palate around 17 millimeters. But really what we're looking is for the transition zone for where the palate moves vertically to where it moves horizontally, and where those converge are where we're typically going to find our artery and our nerve. I was actually afraid to follow that recommendation, but Ricardo Kern was the guy who really told me that's what he does every single time, and he does not have an issue. So I've gone with that ever since, and I have not had an issue either. Graft thickness is what we see really impacting post-op pain when we take an autogenous tissue graft. So how thick is the graft? We want it to be less than 2 millimeters. And we want to take it from an area that is as thick as we can find. So the residual tissue thickness and how thick we take of the graft, those two we find to really impact post-op pain on the roof of the mouth. So I want to take it as thin as possible, less than 2 millimeters, and from an area that is very thick. So this is how I go about doing that. I bone sound with my my needle, and I'm looking for an area that's very thick. Typically, according to studies by Egger, for example, this is going to be in the premolar area. So I check the premolar to start because I know that's what what studies show it's going to be. You can typically even see, like right there, the premolar area looks like there's a little bulge in the soft tissue. And then I start harvesting. So I take my blade, and the big thing to understand here is that the very tip of the blade is the active point on the blade. That's what you're using to cut here, okay? So I insert my blade 2 millimeters deep. I follow that line twice down the entire length of the graft. Next, I put my blade in, and you see that I'm gonna cock it sideways right there. And what I'm doing there, I'm taking the very, very tip of my blade, and I'm positioning it, so I'm pointing it toward my graft that I'm harvesting at 2 millimeters depth. And all I'm doing is I'm pushing that point toward my graft as I drag my blade anteriorly. So I'm literally just taking the point, putting it at 2 millimeters, pressuring toward my graft, and dragging forward. The only other thing that you need to be aware of is where the leading edge of your blade is. You want that leading edge to follow your initial incision. That's why you see my blade kind of cock horizontally, because I'm taking that blade leading edge and following my initial incision. Here you see it even more. Well, let's go back to that. I put my blade in 2 millimeters deep. I press sideways. I rotate so that my leading edge is following the incision line, and I go forward. Now, after I get a little bit of space, I'm able to go full thickness through my graft and undermine the entire graft in one swipe, come up at the most anterior portion, and then draw a line down on the more palatal aspect. And now I've pretty much harvested my graft. So that is a very, very quick way to harvest. Average graft takes, this video took 3.5 minutes to harvest that graft. So very, very quick harvesting technique. Just one more other note to say, in that same study where we saw buccal bone thickness reduction the least when you graft the gap, we also see the least amount of recession when we do soft tissue grafting at the time of the implant placement. I like autogenous tissue just because it's very, very forgiving. If you get a little bit of an exposure, what's going to happen with an autogenous graft? It's going to fill in with keratinized tissue. So I like autogenous tissue. I use non-autogenous very often, alloderm typically, but just to say I like autogenous the most. So after that, showing through the case, I'm just going to show a quick video of how this case went. And so this is where, oh, that line should not be there. Oh, no, no, no. Hold on, guys. This just is to sum things up.
We do have another question before you move from there.
Sure, yeah, absolutely.
Yep. So Dr. Ferris is asking the question, if the buccal bone is missing or does not exist, is the socket shield an indication or a contraindication and should proceed with extraction in class 2 socket repair?
That's a really great question. So it depends for me on, you're talking about a class 2 socket. If I have infection causing my class 2 socket, if I have any mobility at all, obviously I'm not going to be doing that. But the key thing that we need to make sure that we have is we need enough buccal bone to have a stable shield. So that's why one of the contraindications that we saw that was in the Gluckman paper is a severe dehiscence. So if I have complete loss of that buccal plate, I don't have enough bone to actually stabilize my shield, and that's what I need. If I want my shield to be at least 1/3 to 1/2 of my root length, that means that I need some buccal bone to actually preserve stability of that plate. So I like, if I have a very, very thin buccal plate, that's more ideal than if I have a complete lack of a buccal plate, because I'm worried that I'm going to lose stability of my shield in that case. So great question, though. Really, really great question.
Yeah, and he just followed it up by thanking you for your time and being so thorough with the detailed lecture and well-documented cases.
Oh, thank you so much. I appreciate the comment. Yep. Thank you very much. And sorry for going over, guys. I know you're getting 1 CE here, and I'm going to be going like 2 minutes over that. So I'm sorry for that, guys. So this is just the whole case kind of step by step so that we can put it all together here. Okay, so in this case, we had a very minor recession in this case that you can see there, probably just a millimeter in this. But I had mentioned this to the patient, and she, after that, could not let go. I had a recession. I don't want recession. So she actually was really pushing for a soft tissue graft. So I ended up doing a connective tissue graft in this case. In this particular case, we just went with the C-shaped shield, as I showed earlier, using those twist elevators to pop that palatal fragment away, sectioning my root all the way down through the apex, removing that apex from the socket, twist elevator to pop that off the palatal wall, thinning out my shield so that it's at least about 1.5 millimeters thick, down to the bone crest, nice and smooth, beveled at the coronal aspect for 2 millimeters. Always placing my implants guided. Thank you very much, 3DX, for providing the guide for this case. Got great primary stability with my tapered pro-conical implant from BioHorizons. Nice positioning of our implant with the shield there. I'm grafting my gap. This is with Minoros from BioHorizons. Doing my soft tissue graft here, just doing some tunneling, releasing the tissue. After that, we're just making sure we have a little bit of movement there. We go and we harvest our graft in the way that we just talked about, using just the very tip to pressure toward the graft. I do my deepithelialization on the counter. You can do it with a burr. There's a study that's going to come out soon that shows that the burr is actually more accurate. There's positioning the graft there. There's my provisional. I steam clean. There's a study that actually Naif Sanada, if you're familiar with him, his designer Kite Sato published a study that showed steam cleaning can improve epithelial adhesion to your provisionals. Coronally advancing that, this is what we looked like at immediate post-op. And at 2 weeks, you can see our healing looking really nice here with our coronally placed margin, with our margin reestablishment therapy performed, as Jonathan Esquivel says. There's our implant, pros concepts followed, aesthetic biological contour concepts followed. This is really set up for some very, very nice stability. So, and actually, this patient just came in today for her 2-month follow-up. So I'm going to be changing out her provisional now for a full contoured provisional and then sending her back to our my referring doctor here. So really all I'm going to do is ask 3DDX for, hey, can I get a fully contoured provisional now? They're going to send me the final contoured provisional, and then I'm going to put it in, and that's going to put our tissues where we want it. Occlusally, you can see nice soft tissue thickness there on that implant as well. So very nice stability there. So with that, I want to thank everybody. I want to thank all the vendors again for their support here and at the Mish Institute. BioHorizons, Vulcan, 3DDX, Power Dental, CareStream, guys, these are very, very great for my daily practice. And I want to thank them for being here, and thank you for your attention. I'd love some questions if you can give them. I'm sorry, guys, for going over. I tried to keep it down to 45 minutes, but I definitely overshot. So sorry about that.
Totally fine. And there are some questions if you want to handle them. Kind of, we'll do like a rapid fire just so we can let those go that have, you know, screaming babies in the background, which they don't. I just thought I'd throw that in. So thank you. It's completely informative. So let's do rapid fire. So we have the first question is, do you suggest, did you suggest guided for all implants or just socket shield cases?
Very good question. I personally use a guide in pretty much every single one of my cases. That first study that I showed, that was for implants in general. That wasn't just for an immediate implant case. So the deviation that we see can be up to 2 millimeters at the apex, 1.5 millimeters at the platform when we're doing freehand. So that's with very experienced clinicians too. So you know, things happen. Having a guide makes it very, very predictable. The other thing that I find, patients love it when I tell them, when I'm in a treatment conference with them, I tell them every time, I do your surgery before the day of the surgery. I plan it all out digitally. I meet with people to discuss it. And this is, for some people that have a little bit of anxiety, that's the selling point. The fact that I have a guide and that I've already done the surgery, that is a big, big selling point for them. And also, if people are worried about like paying for the guide or things like that, you charge out for the guide, and the amount that I charge for the guide is more than I'm paying 3DDX to make the guide. So it ends up working out very, very well, and you've got an added like 5 minutes in order to, if you need to meet with them, to plan the case. So yeah, I pretty much use them in every case, unless it's a posterior case and there's limited mouth opening or things like that, but pretty much every case.
Perfect. We've got a few more here. So, and rapid fire. So don't make me hurt you and like run through your linebacker defense. Do you still do the socket shield technique if the tooth initially was at grade 2 or 3 mobility?
No, absolutely not. If I have mobility of the tooth, that is not a time that I'm going to be doing a socket shield. Really important that we have very nice stability of the shield.
Perfect. And the second question from Dr. Obata is, do you prefer any specific grafting material if you're going to fill the gap between the implant and the socket shield?
Great question. Obata, love you, buddy. I miss you, man. Really good question. So in the literature, they use allograft or xenograft. I've seen it both published. What I'll say is this. If I need volume stability, I use a graft that gives us volume stability. That's xenograft or cortical allograft, right? When I have a socket shield, I'm preserving my buccal plate. That's giving me volume stability already. So I don't need a xenograft in there. I would rather have something that's going to remodel and turn into native bone, which is cancellous allograft. So So that's what I choose for my socket preservations and for my socket shields.
Perfect. And of course, we'll finish out with what he said. Amazing presentation, Habibi. And we know that that is a term of endearment. So yeah, had to make sure that I included that. We have another question. Oh, from our play-by-play high school football from down in Georgia. He's asking fees for guide, temp, socket shield, etc.
Fees for guide, temp, socket shield, etc. So for the guide itself, I think ends up being about $300. Am I right there, Greg? Does that sound about right?
Your ballpark for sure. And Dr. Michael, we can certainly get that over to you as well and make sure that you've got all of our fee structure, just depending on whether you need all of it, production, design, soup to nuts, or just parts of it. We'll make sure we get that to you post webinar here for sure.
That's going to be way more accurate for you. I'll tell you, in my practice, I charge $380 for the guide to the patient. So that is typically more than what it ends up costing me to have it printed. So
nice. And we'll close out with two things. So Dr. Mike Matias, go Birds, not a question, just a Super Bowl prediction. I mean, that's NFC there. We can't go against the Lions. I mean, that's just really trying to bait the presenter and me. So I love it, though. We said we wanted to stir the pot a little bit. And Dr. Page, nicely done. Your grandfather would be very proud of you. I had the pleasure of being in the same class with him and then went on to Perio as well. Glad to see you taking over the Institute. Well done. Love that. And then Dr. Kevin, 3DDX is cutting edge. Their support systems are second to none. Thank you for that, Dr. Kevin. And with that, I'm going to go ahead and wrap up. Dr. Jonathan Mish, thank you so much. I love the learning. I love your attitude, and you make learning fun, right? And I mean, it was incredible. There was so many pearls in there. I can't even. So thank you everyone for attending tonight's CE webinar, Beyond the Pros Concepts. I got it right. Achieving optimal tissue stability with socket shielding and surgical guides. Thank you to all of our sponsors as well. A link will be sent within 5 business days from our marketing department at 3DDX, instructing you how to receive your CE credit for tonight's program. Again, we thank you for your time and attention. Lastly, we at 3DDX appreciate your business. Have a fantastic night and be safe out there, everyone. Be well.
I'm going to say really quickly to anybody that's still around, if you have questions still, because I see Henry, you've got a hand raised here, please DM me. I'm happy to answer all of your questions like anytime. Just ask me questions. My Instagram handle is down at the bottom right at Dr. J Mish. And if you want to email me a question, I'm just drjmish@gmail.com. Okay, guys. So thank you so much again, guys, for tuning in.